Hi there, so today we're going to speak about the management of traumatic brain injury and status epilepticus and how ITU is involved in neuroprotection. So firstly, what is traumatic brain injury? So there's lots of different definitions out there, but having looked at sort of several of them, I sort of summarised it down into being when an external force causes damage to the function and structure of the brain. I'm just going to focus a little bit on the neuro injury and ICU involvement. Obviously, we're always thinking from an A to E approach, and in ICU, it's always about very much having a supportive element and sort of trying to keep as normal parameters as possible. So obviously, airway and C-spine are very important when it comes to neurological injuries. So having a plan with airway and appropriate immobilization of spine and positioning is very important. And then thinking about breathing, we're obviously thinking about the biochemical parameters, so it's how we manage oxygen, carbon dioxide, and how we manage sort of risk as well, and what our ventilation strategy is going to be. And obviously, blood pressure is extremely important with neurological injury, and maintaining that with any sort of vasopressors or inotropes we may be using as well. To focus now on models of brain injury. So these can either be primary or secondary. Primary focuses on when there is axial loading and shearing forces on the neurons and between brain structures. And this can present either in contusions or extradural or subdural bleeds. And there's also the sort of secondary injury, the sort of the impact of the failure of adequate oxygen delivery. This can lead to reduction in blood oxygen content, reduction in blood flow, and also can present with fits and fevers when there is increase in oxygen demand. I'd like to just spend a minute here speaking about the Monroe-Kelly doctrine, which is something we've probably covered in our studies, but I think it's good just to refresh everyone's minds on this. So basically, this doctrine describes the skull as a closed, rigid box with a fixed capacity. The contents are split into three aspects. So there's the volume of the brain, there's the CSF, and then there's the arterial and venous blood. There may be other aspects here as well, including tumours or hematomas. And basically, if the volume of one of these substances increases, in order to maintain constant intracranial pressure, the volume of one of the others must decrease. And initially, this can be achieved through a compensatory mechanism known as compliance. And an increase in the amount of blood in the skull will lead to a compensatory decrease in the amount of CSF, and normal intracranial pressure will be maintained. However, as with anything, this compensatory mechanism will get to a point where it becomes overwhelmed. And at this stage, small increases in the volume of any one of the three substances can lead to a dramatic increase in the intracranial pressure. And if this is left untreated, it will lead to progressive reduction in cerebral perfusion, herniation of the brainstem, and ultimately death. So as we said, there are some key points that we focus on in ITU when we're managing traumatic brain injury. I'm just going to pick up on some of the key points here. So deep sedation is often used in order to reduce brain metabolic rate and to reduce the likelihood of fits. We also need to have a very specific MAC range between 80 and 100, and this helps to maintain cerebral blood flow. Positioning, as mentioned, touched on before, is very important with the head up 30 degrees to reduce venous blood resistance out of the head. And furthermore, thinking about sodium, this is very important to reduce the chance of cerebral edema, and also managing glucose, as high blood sugars can induce cerebral lactate and worsen outcomes. Quick touch here on some of the medications that we use to treat raised intracranial pressure. So firstly, we've got mannitol, which is called rapid and effective reduction in intracranial pressure. However, in some cases, the diuresis and fluid loss can lead to sodium problems, and in some cases, you can get rebound intracranial pressure rise in 2 to 3 hours. As it's an osmotic diuretic, there is also risk of AKI, so that needs to sort of be carefully monitored. Hypertonic saline is also commonly used, and this creates an osmolar gradient which allows cerebrospinal fluid to move through the cranial space, leading to a decrease in intracranial pressure. And finally, there's also a role for sedation bonus. And this helps to reduce cerebral oxygen demand, so ensuring adequate sedation under paralysis. I'm just going to focus on this paper, which is readily available over the internet. It's looking at the most updated guidelines for the management of severe traumatic brain injury. And it's obviously quite a dense document, but I'll just focus on some of the key points, picked out some of the things that have sort of changed that people possibly didn't know. So looking at this, one thing that I sort of found particularly interesting was prophylactic hypothermia. So it advises in this latest edition that early classes within 2.5 hours, short term classes 48 hours post-injury, prophylactic hypothermia is not recommended to improve outcomes in patients with diffuse injury. And this was sort of felt as there is, by maintaining this prophylactic hypothermia, there's a risk of coagulopathy, a risk of immunosuppression, and there's also a risk of cardiac dysrhythmia, which can potentially lead to death. So that's something now that we're not sort of doing at all, it's not advised in the literature. As we touched on, hyperosmolar therapy, mannitol is sort of very effective. However, there should be some caution using it prior to intracranial pressure monitoring if there are signs of sort of herniation in people as well. And also thinking about ventilation strategies. So previously, hyperventilation was sort of recommended, and whilst it is still recommended as a temporizing measure for reduction of elevated ICP, evidence suggests that it should be avoided during the first 24 hours after the injury. And some other sort of key points I thought out here was sort of steroids. So steroid is currently sort of not recommended for improving outcomes or reducing intracranial pressure. And it was actually found that high-dose methyl prednisolone is associated with an increased mortality and is actually sort of contraindicated as well. And also, there was sometimes phenytoin is often used as a seizure prophylaxis. However, this was not recommended for preventing late post-traumatic seizures. However, it is recommended to reduce incidence in the earlier stages. So when it comes to monitoring, there is specific guidelines about when we should carry out intracranial pressure monitoring. And they say it should be in all patients with a TBI and abnormal CT scan. But if they have a normal CT scan, then if 2 or more of these criteria are met, then we should also do routine intracranial pressure monitoring for that as well. So then also looking at the sort of threshold recommendations. So obviously we want to maintain blood pressure, and as we can see, there's a sort of slight difference with target blood pressures depending on the age, and it's advised if intracranial pressure is above 22, then that's sort of threshold for treatment as well. And as I said before, in ITU, obviously we need to keep things within certain parameters, and cerebral perfusion pressure is one that needs to be kept between 60 and 70 for the most sort of favourable outcomes. There's some evidence to say that aggressive attempts to maintain it above 70 does carry a risk of adult respiratory failure. So I'm just going to think here a little about status epilepticus. So a lot of the traditional definitions focused around a seizure going on for more than 30 minutes or multiple seizures of shorter duration without full recovery in between. And as new evidence has emerged, there has been some changes in this sort of these definitions, and there is sort of more discussion around how we should define status epilepticus. And it's felt that the majority of sort of seizures in adults will actually be less than a minute. So for any seizure persisting beyond 5 minutes, it does represent a significant deviation away from the norm, with a suggestion that neuronal injury can result after just 5 minutes of seizure activity. So some definitions now would support a diagnosis of status epilepticus for any seizure that persists beyond 5 minutes without definition. As I say, these terms it's all new evidence and terms. Different terms are being used, and in some cases they're more using a term sort of impending status epilepticus to define certain situations as well. Just quickly going to touch on the management, which we'll go into more detail in the next lecture. So obviously, as with any sort of medical emergency, ABCDE approach is vital, and having early sort of maintenance of that airway and having someone suitably airway trained is our #1 priority. Apply high flow oxygen. Obviously, we always want to be thinking about what is the cause of seizure as well. One of the most common things is hypoglycemia, so obviously checking that early is vital. And thinking also about, obviously, access is really important, as usually in hospital, the first port of call is to give IV lorazepam, sort of 4 milligrams. We do have the option of buccal, which isn't always available in the adult circumstance, or PR diazepam as an alternative as well. And going down to all the treatment algorithm, usually they recommend repeating lorazepam at the 10-minute stage if the seizure continues. As I said, we always want to be thinking about what's going on as well. So there's a role for pregnancy, for Pabrinex, if there's suspicion of alcoholism or malnutrition. If we think this is a pregnancy-related fit, then there's consideration for magnesium sulfate. And obviously, thinking about reversible causes, getting ABG, getting early electrolytes and bloods, and then thinking about anything else that could be going on, such as a head injury or any sign of infection or meningococcal involvement, then we want to be sort of carry out appropriate treatment down those lines as well. And as per sort of all of the guidelines, once we get sort of 30 minutes, we need to be thinking about loading up phenytoin, possible rapid sequence induction as well, which we'll go into in the next lecture, focusing more on the drugs. And as I've said, having somebody anaesthetic trained there in order to deliver the drugs, to maintain the airway is vital, and involving them at an early stage is very important. So yeah, that's any questions.